Sound check 1 2 3. Sound check 1 2 3.
Hello and welcome to the Board of Health for December 1st, 2025. I'm your chair, Ward 2 City Councillor Cameron Crutch, and joining me in the room are members Ryan Jansen, Chelsea Kirkby, Councillor Mark Chattison, Councillor Tammy Huang, Member Don Danko, and Councillor Alex Wilson. And joining me online are Member Sarah Jacob and Vice Chair Emil Joseph. Welcome to the meeting. We have quorum for today's meeting, so I'm going to call it to order. The approval of the agenda is our first item of business. So I can have a mover and seconder to approve today's agenda. Moved by Councillor Huang, seconded by Councillor Tattison. Any amendments, questions, suggestions about the agenda for today? Not seeing any. So by show of hands, all those in favor of approving it. And that is everyone, and it carries. We're on to declarations of conflicts of interest. Does anybody have a declaration to declare? Not seeing one, so move on to approval of the minutes from our previous meeting, which was October 20th, 2025. Can I have a mover and seconder to approve the minutes of our previous meeting? Moved by Councillor Huang, seconded by Member Kirkby. Any questions, edits, concerns, thoughts about our minutes from the past meeting? Not seeing any. All those in favor by show of hands. And those minutes are carried. Thank you. We're now on to delegations, and according to our agenda today, we have two delegations. The first from Gloria Nastos respecting solutions to the opioid crisis and the overuse of drugs. Before we begin our delegations for today, members are reminded that questions of the delegates are for clarification purposes only and not for debate. And a note to our delegates, you have 5 minutes to complete your delegation, and you'll hear a tone at the 4-minute mark, and you'll have an additional minute to finish up. Is Gloria here today? You want to come down for your delegation? Whenever you're ready. And Gloria, just so you know, on the left-hand side of the desk, there's a little toggle switch. You can move the desk up or down so the microphone's in the right place for you. Don't lean too close to the microphone. It'll pick you up, and it'll start once the red light of the microphone turns on. Your delegation will start. Okay, the light is on, Gloria. You're ready to go whenever.
Okay, hi. Through the chair, I wanted to discuss the opioid crisis going on in Hamilton, Ontario, and how the dosing is out of control, and provide a solution. If I was public health, I would find a solution to take some type of control. Most opioid deaths are caused by polypharmacy, more than one drug. Public health should have a role when, for example, when one of the drugs, marijuana, was decriminalized. There was no medical instruction. Like, every medication comes with instruction how to take it, when to take it, but now it's so out of order and the dosing is so out of control that it's causing harm to humans. And I would try to put it back in its original classification to the decriminalization of marijuana. It's still a crime because it's causing so much harm to humans, and it should be placed back to its original function. Its original function and purpose should be respected. So I think that the decriminalization of marijuana, it's still a crime. It's caused the greatest assault, mental assault, to humans in history. I would close down the marijuana shops temporarily. There's 24-hour marijuana sales going on. It's completely out of order, and try to find a strategy like to keep them open maybe 2 hours a day, 3 hours a day, 4 hours a day, to control the out-of-order dosing. So the people who take the medication, the marijuana and these narcotics, all these addictive drugs, would get the idea that they can only take it at that time. Maybe that would control it a bit since they closed down the dosing stations. Another problem is like where you're supposed to smoke it, they can smoke it anywhere. And especially like when they're picking up their kids from school, they're smoking it and they're walking their kids and their kids are breathing it in. I think that's another crime, unfair to children to breathe it in. It's messing up also their concepts, how they think about these things, and it's going to affect their experience. I think that public health should take some sort of control in it. That's how I would do it if I was public health, and just to protect, for safety of humans, safety and protection of our health. And also, public health should play a role in the homeless, also, the infectious disease and homelessness. These things are hardly ever talked about. So to put it back in, marijuana should be put back in criminal status. The people that are homeless and on drugs, they are not given the necessities of life. That's what I'm witnessing. That's what I think the way I can define what I'm witnessing is they don't have the necessities of life. And the province commissioned the city $23 million to take care of that problem, and it's the city's responsibility. For the naloxone kits, they're for the public to use them for, say I was, in a situation to help someone who was in crisis and to use a naloxone kit, I'm not trained. Those kits are used by emergency services, emergency departments in hospitals that are fully trained and know what they're doing. And I just found that the McMaster University second-year medical students were saying for the public to get involved on the last meeting and to use those kits. But the thing is, when you give them those kits and they can go back into emergency crisis and you have to use it again.
Thanks, Gloria. So your time is over by about
emergency.
half a minute now, so I'm going to ask you just to hold there for a moment because there's a question from Councillor Huang.
Yeah.
Thank you for your delegation today.
Thank you.
Have you thought about writing to the Member of Parliament, so at the federal level, all of your concerns?
I've done it.
Okay.
I've talked to them on the phone several times, given them ideas.
Okay.
Had a conversation with Donna Skelly, everything.
So Donna Skelly is the Member of Provincial Parliament, but you may want to think about Member of Parliament, so at the federal level. But thank you for your delegation today.
Thank you. Okay.
Thank you for your delegation. Up next on our delegation list is Kayla Haggerty, respecting overdose deaths in Hamilton, 2025, alternatives to heart hubs, SCS closures, and the need for continuity of social supports. And Kayla joins us online. Kayla, you've got 5 minutes. Whenever you start talking, go ahead.
Cool. Sorry for my pajamas. I just woke up. But
You
good
and your
morning.
pajamas are both welcome here, Kayla.
Thank you. My name is Kayla Haggerty. Good morning, members of the Board of Health. I am 26 years old. I'm a sociologist and epidemiologist in training, a harm reduction researcher, and a sober woman in recovery. I also stand here as the daughter of a man who died from a drug overdose during the COVID-19 pandemic. a death that was preventable. So my academic work, including a 3-hour documentary produced alongside my master's thesis at Carleton University, examined how social disruption like the pandemic magnified the opioid crisis. But today I'm not speaking to you about that, and I'm not talking to you as a researcher, I'm speaking to you as a Hamiltonian, as someone who lost her father, someone who survived addiction herself, and somebody who understands in a way that no data table can describe what service disruption can do to people who use drugs and the families who love them. So when we talk about Hamilton's situation, right now we're at a breaking point. So across Ontario, including here in Hamilton, the province has legislated the closure of supervised consumption services by March 31st, 2025. So this has already happened. Shifting to the new Heart Hub models, which we've seen opened up across Ontario. These hubs do not include supervised consumption, needle exchanges, or drug checking, the very much needed interventions proven to prevent overdose deaths. Meanwhile, Hamilton's data paints a stark picture. So from January 1st, 2025 to November 16th, 2025, Hamilton Paramedic Services responded to 971 incidents related to suspected opiate overdoses, sorry. Hamilton paramedics also responded to 142 suspected overdose, oh my God, suspected opiate overdose calls in both August and September 2025, breaking the previous 134 set weeks earlier in the 134 people set weeks earlier in July 2025. So it went from 142 to in August and September. No, sorry, went from 134 in July to 142 in August and September. In 2024, Hamilton's opiate-related death rate was 46 times higher than the provincial rate, and it remains drastically higher than pre-2020 levels. So, for example, 167 deaths in 2021 compared to 52 deaths in 2016. In 2025, as of July 31st, Hamilton has already recorded 43 probable or confirmed opiate-related deaths following persistently high totals in recent years. So 129 deaths in 2014, for reference. And these aren't just numbers. These are Hamilton residents that we're losing. These are parents, siblings, co-workers, neighbors. These are family members who will never recover. And Hamilton isn't we're not on the margins of the crisis. We are the epicenter of it. And these closures matter because when safe consumption sites disappear, the closure of services must not be interpreted as a signal to stop caring about people who use drugs. It's a signal to get creative and get resourceful and protect lives by any means necessary, any ways possible. Because people who use drugs are still your city's residents. We're still part of this community, and we still deserve care. And we know, not abstractly know, not theoretically, but from decades of frontline evidence and scientific research, that when drug consumption sites close, overdose deaths rise. Without drug checking, people unknowingly consume increasingly toxic drugs, sorry. When trusted peer relationships disappear, people stop looking for help. And when harm reduction systems collapse, unsafe public drug use increases, and that affects the entire community. These aren't assumptions, these are lived realities, and they're documented with outcomes. And Heart Hubs, as they currently stand, do not fill these gaps. People at the highest risk, unhoused residents, people with trauma histories, people deep in withdrawal, people who fear police contact. These are not people that are entering these hubs, and these are the people who need these resources the most. This model is not accessible for the very population it claims to support. And if a service does not reach the people most likely to die, then it's not a functioning service at all. This is personal for me because my father died in a moment of service disruption. His death was not inevitable, it was systemic. Health Canada reports that there was a total of 53,821 apparent opiate toxicity deaths reported between January 2016 and March 2025. Over 95% of those were accidental. After losing him, I fell into addiction myself: crack cocaine, fentanyl, alone, afraid, disconnected. But I survived because people reached me where I was: peers, outreach workers, harm reduction staff. If I didn't have a safe consumption site to access, or I didn't have marijuana to smoke as an alternative, or I didn't have people to speak to for support, I wouldn't be here today. I would not be standing here today. I would be another statistic. And I can't sit here and allow for any more families to face what I have or what my family did, and I can't allow any more disruption to mean death. So, what Hamilton can and must do immediately, I'm not here to sound the alarm. I'm here with solutions that are practical, evidence based, and urgently needed. So, regardless of us lacking safe consumption sites, we have the YWCA one, correct? The 24/7 Women's Center based one. Why don't we fund or put more money into the services we already do have? Or even create, like, we guarantee that there's no gaps in services or overdose prevention sites. So like there's mobile overdose prevention units in different cities that are popping up. We can look to the anchor model in Ottawa, Ontario, and create little things like that. Have a van driving around, not just the AIDS van, or like little things like that. Bigger ideas, like more succinct models that actually, yeah, I'll stop, that actually go deep into the centers of where people are that need help. Expand and fund existing models, like I said. Build a real continuity of care. So connect harm reduction, treatment, mental health, shelters, housing, primary care, using peer navigators throughout, and reestablish the overdose prevention task force. But yeah, just do something, because to do nothing or to do anything less than everything that you possibly can is to knowingly accept preventable death. But thank you for your time and your service.
Thanks very much, Kayla. I'm looking around to see if there are any questions for you at this time. I'm not seeing anyone on the speakers list. I'll look around the room just a second. Yes, Member Jansen, go ahead.
Awesome. Thank you so much for your delegation. A lot of really good points and comments. I'm curious, a lot of what you describe is work that is ongoing with various groups across the city. And I look to the Hamilton Drug Strategy and the Opioid Working Group in particular, and a lot of the really good work that's going on there. And a lot of what you mentioned are points and discussions that are happening in those tables. But I'm wondering if there's sort of a disconnect between, again, a lot of that ongoing work and maybe the ways that community members and the public are able to see some of that work actually happening on the ground. I'm curious, did you have an opportunity to look into the Hamilton Drug Strategy or any of the work that they've had underway?
Yeah, I've looked up a little bit of it. A lot of what they're focusing on right now is kind of what was mentioned in the last delegation, kind of educating on naloxone and stuff like that. That's been a really like big focus, and I know that they're trying to like educate people and stuff. But I find, which I think is a great idea, but I also think like yes, we need to educate people, but I think we also need to focus on the actual services at hand, the bigger picture. And like you know how we opened up that urban core thing and now it's just sitting there? What are we going to do with that huge facility? What are we thinking of? Like, I want to see the action, not so much the talking, because I feel like it's all lip service when it's on paper and not in practice. You know what I mean? And not to say that they're not doing anything at all. What they're saying is fantastic and these ideas are fantastic, but let's put them into practice and see if they work, because sitting here doing nothing isn't working and people are dying. So that's just my opinion.
Well said. Thank you.
Thanks. I don't see further folks in the speakers list, so we're going to move to receive both of these delegations. Oh, pardon me. Vice Chair Joseph, you had a question? Go ahead.
Hi there. No, I appreciate the delegation, and it does, like the other member was mentioning, speak to some of the responses to the worries raised, through this board around the closure of supervised consumption sites and what we do to recognize the impacts of those, report on them, and plan actions in response to them. I really did appreciate the kind of numbered list of actionable items that the delegate shared with the board, and I agree with many of them. I think there are
So Vice Chair
immediate.
Joseph, we're just at the part where we're asking questions of the delegate. So did you have a
Yeah,
question
I'm,
for her? Okay.
yeah, I'm getting to the question.
Okay, great.
It begins with an appreciation of what's there to get to the point of prioritizing which are the 5 steps. So in item 1, it's to implement an emergency continuity plan, and under the 3 steps, mobile overdose prevention units and pop-up models that exist in various places, shelters, libraries, drop-ins, that kind of thing. So that mobile intervention process would be one. I would say, the peer support model, people could talk about in various ways. The second one that stands out to me is kind of scaling up naloxone at all public facilities and looking at safe supply pathways as well as naloxone distribution in there. I would say of those, which for the delegate, um, which ones do you think are highest priority? And maybe staff can respond to this. Which ones currently are in process and do exist or being looked at?
Am I supposed to talk? Am I allowed to respond to you? Am I supposed to respond, or is the yes?
Yeah,
Okay,
that's a
fine.
question for you
Okay,
about
okay, okay,
prioritizing.
Kayla, yeah,
okay.
that's why you're
It's just
here. The
because
question's for you.
Okay, okay. No, I just didn't know because you were talking to the council too, and I didn't want to talk when I wasn't allowed to. Okay. So my opinion would be we already have naloxone everywhere, so I would scratch that. Not safe supply pilots have already happened in different cities, and there's lots of different opinions on them. So I would scratch that. My important thing would be drug checking because I think at the height of all of this, people just want to know what they're using. The idea is not to stop drug use, but to give, like, you know how the LCBO you go when you want to buy alcohol, you know exactly what alcohol you're buying, what percentage, what's in it, blah, 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 blah. You know what I mean? Why is that not a thing for people who use drugs, even if they're street drugs? So if they have the FTIR and like drug, like there's drug checking machines that we can put in different facilities, like YWCA or the Urban Core, where people can bring in their pre-obtained substances and have them checked for what they are, and then they know whether or not to use them or to go low, go slow. You understand what I mean? So I don't think any of those things are actually the important ones, the naloxone or the safe supply, because both of those things are already happening. What's not happening is the drug checking and the extra, like the resources that BC has. If you look into like the BC model, they have more of a progressive model when it comes to responding to addictions. But that's my response. The drug checking.
Thank you.
Thanks. And before I turn to the next person with questions, just a couple brief housekeeping items. Welcome to Councillor Narinder Nan, who joined us. Welcome to Dr. Rami Safi, his first meeting here at the Board of Health. Welcome.
Thank you.
For being here. And Councillor Craig Gassar is joining us in the chamber. He was late because he's just been appointed the vice chair of the Budget Committee and had to attend a last-minute meeting with the Budget Committee folks. So thanks all for being here. Turn it over to you for questions. Dr. Safi.
Thank you very much. Kayla, thank you very much for opening up on this and being courageous to speak about your experience. Do you think that the city staff, as well as most of the people who are not directly working with substance use and healthcare, need more educational systems where we enhance the concept of the model of BBS, which is biological, psychological, and social factors, instead of the moral model when it comes to addiction. As a pharmacist and a psychotherapist myself, I saw lots of substance use patients, and the biggest issues, and you mentioned them already, with biological and psychological and social aspects of this. Do you think that there is a huge need for this from a city place where we need to really enhance systematic education about this?
Yeah, so my mom actually works for the city. She works for the building department. Please don't tell her I told you guys that. She'll be very upset. She doesn't like to be tied in with my work.
This is a public meeting, so unfortunately she now
That's
will
okay.
know. So no
Sorry,
secrets
Mom.
here, Kayla.
Oops. Sorry, Mom. But anyway, she is in the city of Hamilton watching me. And so from that, I know that she was not trained on overdose responses. The city of Hamilton does not provide overdose response training, does it? In your training when you become part of the city as an employer. And I think that's insane considering the highest number of overdose deaths and overdose responses happen just around the corner from the city hall. So I think we need to reconsider that. I think it should be mandatory in your training for all city councilors and all city employees to learn overdose response training, because you guys are at the forefront of this crisis. You guys are supposed to be the ones that the city looks up to. Does that make sense? Sorry if I went a little overboard, but
Yeah, that makes sense. Did you have a follow-up question, Dr. Safi?
No, it does make sense. I'm also talking about the fact that in that education, we need to enhance more thoughts on why that substance use is really a mental health that is
Yeah.
affected by many of the social and biological and psychological factors, and that's where our root cause of trying to solve the problem instead of being proactive, mainly being proactive about it. But thank you very much, Kayla.
Yes. Yeah, no, I agree with that. It's more than just it's not a choice. Addiction's not a choice. People don't wake up saying I want to use drugs. It's so many different things happen in your life to lead you down that path, that the reality you're living in right now is not the reality you want to be in, that you find alternative realities to survive in. But that's all for me. Thank you.
Thanks very much. And next up to ask a question is Member Jacob. Go ahead.
Good morning, and hi, Kayla. I wanted to say thank you so much for your presentation, and specifically speaking about your lived experience and the things that your family has experienced as well. I think your experience really highlights how intergenerationally this crisis is experienced and how those policy failures have greater repercussions down the line. So I'm curious because you did mention specifically the passing of your father. I'm so sorry for your loss. And I'm really curious about how you understand the policy disruptions that contributed to his passing and how you link that with the current issues that we're seeing. So I was hoping that maybe perhaps you could, or if you could please expand on what you understood as a policy failure that occurred at that time and how you see that connecting with the current context.
Yep. So for my thesis, I had four findings. So the first finding was the lack of access to community supports. So a lot of like the stay-at-home orders and things like that, border closures, disconnected people from their families and their communities. So that made it harder for people to seek supports. Then the mental health impact of isolation from the pandemic that impacted like people's depression levels and reasons to want to use drugs, increase their reasons for wanting to use drugs. Then I found that the drugs during the pandemic, due to border closures and a lack of access to drug checking measures, issues for drug smuggling, it even down to the deeper like criminal level, it was harder for people to smuggle drugs into the country, and therefore the drugs were more potent and also toxic, more like precarious as to what they were going to be. So there's those three, and then finally like just the closures of all these sites and everything, safe consumption sites, lack of capacity. I may have said that already accidentally, sorry. But yeah, just those things all encompassing made it so that he had nowhere to go for help. And he died in his apartment by himself from a fentanyl overdose. Had there been more open sites at that time or community members, like people going around doing peer checkups, if there were supportive housing like there is now in 2025, like maybe those things wouldn't have happened, right? But now, like hindsight's 2020, now I look back and I'm like, oh, there were so many things that I could have told him about that he could have used to get help, but I didn't know back then. So I guess just the awareness of all the things that are already available is wonderful, but also just amping up the things that are available so that they actually get to the people that they need to get to. Because I find that the people that are homeless, or like people that do not have homes, people who are stigmatized because of their criminality or their like intense mental health issues, those people are not getting the help they need because they're more of a harder case to solve, if that makes sense. And then for my case, what happened to me was I kind of burnt out. I really focused on my career and my education and like just making sure that everybody could see that I was doing okay, that I didn't really listen to my body and my mental health enough to see that I wasn't okay. And then when the opportunity came that I was presented with the substance that was helping other people be okay, I was taking the substance because I thought, okay, this is what everybody else is using to calm down. This is what my dad did. This is what people who are struggling do. And like it worked out for everybody else. It's going to be okay for me, and it wasn't. And if I had the community members that I had prior, and like my friends and my family as closely as I had them before, if I had less on my plate and less stress and like better positive environments, I probably wouldn't have ended up doing drugs at all. But the reality is I did, and now I know for others that maybe, yeah, building community and having somewhere safe to go when you do want to use is what kept me alive. And I would love for a person struggling in the same way as me to have access to that so that they may stay alive as well. I don't know if that fully answered your question, but I hope it did. Thank you.
Yeah, thank you so much.
Thank you. I don't see any further speakers right now, Kayla, so thank you so much for your time here. You can log off and watch the rest of the meeting on YouTube. At this time, we're going to receive both of the delegations. Can I have a mover and seconder to do that? Moved by Councillor Hine, seconded by Member Jansen. Are there any comments or questions for staff about the delegations? I'm not seeing any. All those in favor of receiving them? That is everybody. Thank you so much. That carries. And now we're going to move on to the next part of our agenda, which is items for information. First item for information is the proposed 2026 Board of Health meeting schedule, BOH 25030. Can I please have a mover and seconder to put the memo on the floor? Moved by Member Kirkby, seconded by Member Jansen. Is there any discussion about the schedule for our meetings for next year? I'm not seeing anything. Okay, all those in favor? That's carried. Those are the meeting dates for next year. Thank you. I apologize, actually, we can't do that one by hand. So it was fun that we did a little practice test, but we have to actually do an electronic vote of that, I believe.
So sorry, through the chair, what you would have done is just received the memo. Now we'll need a mover and seconder to bring forward those dates, and then we'll do an electronic vote.
Oh, I see. So we're doing, it's two exciting things. One, we've received the information. Thank you, everyone. And secondly, we're actually going to then do the thing. So we're going to have two votes. A mover and seconder to actually make sure these are the dates. Moved by Councillor Huang, seconded by Councillor Kassar. Okay, everyone, electronic vote. And I'll let you know as soon as the vote is up and available for you to vote. It will take a moment to load. At this time, the vote is loading. And the vote is now available. Please indicate yes or no.
Member Joseph, are you in favor? Thank you. And Member Safi doesn't appear to be in the meeting anymore. So
Okay.
I'll mark him absent.
And that carries 11-0. And now we're going to move on to 7.2, Board of Health 25029, the Hamilton Opioid Information System Semi-Annual Update. Can I please have a mover and a seconder to put this report on the floor? Moved by Councillor Nance, seconded by Councillor Alex Wilson. Is there any discussion on this report? Not seeing any, so I'm going to pass the chair over to self-elected Vice Chair, Councillor Huang. Yeah, I mean, I'm the self in that situation. I elected you to be the in the room, the Vice Chair for today. So if I could pass the chair to you, I didn't have any questions, but I wanted to make a comment. If you look at this report, which I hope everyone's had a chance to do, one of the things I think it's really worth pointing out is the very first chart on page 1. And you'll notice, if you scan to the right-hand side of the chart, that there was a huge spike in paramedic calls in Q1, Q2, Q3 area of 2025. We've recently had some students present and talk about some of this data, and I guess maybe I'd just like to turn to staff to ask a brief question about what you think specifically is contributing to that, if there's anything that comes to your mind, or if there's any evidence you have that speaks to a contribution of that, and if you could say so publicly, because I think it's worth having a brief conversation about that in public.
Dr.
Just introduce yourself.
Okay.
Hello, can you hear me?
Yes.
Hi, everyone. So my name is Shima. I'm the Associate Medical Officer of Health on the file for substance use and mental health. This is my first time in person, and it's a pleasure to be here with you. So thank you for that question. I just wanted to point out that while paramedic incidents have gone up, the overall number of opioid-related toxicity deaths have actually decreased. So we're seeing decreased levels since the peak in 2021, which is generally what we consider moving in the right direction. So whereas our outcome is opioid toxicity deaths, we also look at a variety of other indicators to make sure we have a kind of more complete picture of what's happening. One of those indicators is paramedic incidence reports, and the number of calls they're getting alone doesn't give us a sense of how that necessarily reflects with opioid deaths, because that can also reflect engagement with paramedics, if people are feeling more comfortable to call, if people are having more overdoses in public places. Like, there are a variety of reasons why people might engage with paramedics. So that's something that we're actively looking into as we plan our next Hamilton drug strategy to better understand what's going on there. But just to point out that incidents alone can also be a sign of engagement. So we're just trying to kind of get a complete picture and also let you know that the overall opioid toxicity deaths have been reducing annually since 2021.
Thank you, Dr. Shima, and welcome to Board of Health. Counselor.
Yeah, I appreciate that deaths are down, and that's not really my concern in this moment. Of course, I'm concerned about opioid deaths, but what I'm trying to understand is, are we seeing more calls in and incidents in related to opioid toxicity, people overdosing, that kind of thing? Since we're seeing, frankly, the closure of safe consumption sites, supervised consumption sites, CTSs, SISs, however you want to understand this, the Ford government's done a good job of closing everything they can. And so I think I've named most of the things they've closed. I think it's a pretty obvious correlation here. We're shutting down these spaces where people have an option to use drugs safely, to have the ability to get their drugs tested and so on, to ensure there's a safer supply. And then we're seeing a huge spike in paramedic calls. And that's what students pointed out when they were here. So I guess I'm looking for you to comment specifically on that, or someone too.
Dr. Shima, please.
Sure. So I think that like I said, there could be a lot of things going on. So the question is, do these calls reflect a higher incidence in overdoses? That's the part that I'm not sure about, and my colleagues can also comment on, because like you said, there just could be so many different things going on. To give you one hypothetical, it could be that, let's say, the supervised consumption site is closed, so people who might have had an overdose in that setting could have had an overdose in a different setting, and that could have resulted in a call. The point I was making earlier was just to highlight the difference between the actual number of overdoses going up and the number of incidences going up. And I see Melissa also wants to comment on this.
Hi, good morning. Melissa Bixa, Director of Epidemiology and Wellness, Public Health. Through the Vice Chair to you, Councillor. So again, as Dr. Shakori was saying, while we cannot directly attribute it to policy changes, what we do know is our data intelligence that we hear from the community, and this report highlights that there continues to be a highly toxic and changing drug supply. We also have reports that there is more public use of substances occurring, which could also then subsequently increase the paramedic responses. We are in regular conversations with other, similar public health jurisdictions. I would say that that's being echoed, I would say, across similar jurisdictions, is seeing an increase in paramedic calls, reports of more public drug use happening. And again, we know throughout the province there continues to be a highly toxic drug supply circulating, which makes it really difficult for individuals who are using.
Thanks. And through the chair, my last question is, so how do we find out more definitively? Because I imagine when people are calling in to dispatch, there's some information that's gathered during that phone call. I'm not sure how that data is shared, how we get it, how we better understand what those calls are related to. Could you speak maybe to that a little bit, how we find out?
Yeah, thank you for the question. Through the Vice Chair to the Councillor, that is like ongoing CQI work that we continue to do. The data presented here around paramedic calls is the straight number or volume of call. There is data quality pieces there. You can appreciate a paramedic responding to an overdose and then subsequently ensuring that all the relevant details are captured. So with the data systems with paramedics, that's close relationships and conversations we have with our paramedic partners on what more we can glean from the data that is able to be collected, and then to help continue to pull that picture together. So I can say that's work that is ongoing. to continue to inform. The other piece I would say is we continue to CQI and promote our weekly opioid surveillance report, which is our ongoing data intelligence, which is a qualitative survey that goes out each week, and really highly rely on that qualitative data coming back from community partners around what is happening locally, what are they seeing in the community, what are they hearing from clients. And again, it's another piece of the puzzle that helps to inform our local situation.
Thanks. And through the chair, just my comment on the subject is that, anecdotally also I hear from folks who are providing these services or were providing these services in wards 2, wards 3. And when I speak to them, what they're saying is people are feeling that they're not supported. They're lacking that support. And what that does always is drives up use. When people are feeling afraid, people are feeling isolated, people are feeling vulnerable, they're going to use drugs more than they may have been doing. And what we're hearing from our staff here, which again, I also heard anecdotally, which is that the safe supply isn't really out there right now. There's not as many means and ways for people to get their drugs tested. People are using drugs that are not safe, that are toxic, that are causing overdoses. And, it's really disappointing because I think our community tried for a number of years very actively to put in programs sometimes through pharmacies, sometimes through service providers, not-for-profits, to make sure that there was ways for people to test their drugs. There were places where people can get support, and systematically the provincial government continues to shut those things down and turn people away, and we're seeing those impacts in our community from my perspective, and it's really deeply disappointing and discouraging. I'll take the chair back, and I'll look at my speakers list now. I see Dr. Safi, and then Dr. Emil Joseph, and then Member Jansen. So Member Safi, are you there? I don't see you online at the moment, so that's why I'm asking. So you can go ahead and ask your questions or make your comments. I'm not seeing you there right for the moment, so we'll come back to you in a second. Vice Chair Joseph, go ahead.
Hi. Yeah, the response to the earlier questions were helpful. In the report, the section on health equity data is very helpful as well, including the subsequent sections that say there's a kind of higher degree of impact for those experiencing homelessness. And when we're talking about the social and political context of this report, and the kind of final section of the report where it's talked about as continued work to address the harms associated with the unregulated drug supply, and that continues through the Hamilton Drug Strategy Opioid Working Group and the Greater Hamilton Health Network Harm Reduction and Treatment Working Group. I wonder if you could describe more of what that means in terms of that work as it relates to the impacts of policies whereby people who live outside are being moved around, evicted from parks, impacting their abilities to access services, and some of those analytical points where they turn into actions. Like what is the work that happens in that last sentence that you're doing with those groups that addresses some of these contextual features, like the chair raised the closure of supervised consumption sites, the eviction of homeless people from parks, thereby impacting the kind of care and service needs that they have, and how that is mitigated, responded to, or how recommendations are brought forward, and what people are describing around people's experiences with respect to homelessness in particular, as it was raised in the report.
Thank you, Member Joseph. Through the chair to the member. Thank you for the question. So I want to highlight a few items. So the opioid working group evolved from the Hamilton Opioid Action Plan and Action Plan table that formed as a result of the opioid action plan in June 2023 and led and led the implementation of a number of actions. Since the opioid working group then evolved around the time in the announcement of the CTS closures into the opioid working group to really lead the community response around that. A few, notable pieces that we've talked about was around enhanced data collection to continue to monitor the impacts, which you're seeing here, as well as enhanced communications for community providers as some of those initial system responses. We've had great success here locally here in Hamilton, and two specific projects I want to highlight that have recently been funded by Health Canada and their Emergency Treatment Fund. One funding that's going to the YWCA for women and gender diverse individuals for innovative harm reduction response for the community surrounding YWCA. Second funded project is a partnership between the City of Hamilton, Public Health Services, our Hamilton Paramedic Services, and a number of community partners to implement mobile harm reduction support post overdose event when individuals are the most vulnerable, particularly addressing underhoused individuals. That is in the planning stages and is working to be implemented. Around the table, we continue to hear from other agencies that are looking at wanting to plan and expand naloxone training to community providers, continuing to look to increase access and distribution of harm reduction supplies and naloxone in the community. In 2025, we have seen significant increases in naloxone distribution, both from our Public Health Services Ontario Naloxone Program and also the numbers that we see from pharmacy continue to increase. And again, continuing to distribute some drug checking strips that were part of Hamilton Opioid Action Plan as the drug supply changes, continuing to look at innovative or emerging drug checking opportunities in relation to the ongoing policy changes.
Thank you. That's helpful. I feel like those moving parts, those analytical pieces, and also programmatic interventions would be useful updates for such a report. In my opinion, is that something that would be advanced via motion or something that we could ask of staff going forward?
Through the chair to the member, it could be amended as a particular request. A couple things to note, I will say. The board can expect in Q1 of 2026, and anticipating that could be February, an evaluation on the Hamilton Opioid Action Plan initiatives is scheduled to come back and be reported on. Also recognizing earlier during the delegation, Member Jansen also highlighted around keeping up to date with Hamilton Drug Strategy and Opioid Working Group initiatives. And I think those are things we could also take back to those groups around community communication or communication of initiatives or activities. So we could take that back as a collective to the drug strategy around just ongoing communication of the initiatives that are happening in the community. But back to your further point, if that's something you would like reported back to the board directly at certain times, that's absolutely, that could be a motion that is moved.
Thank you, Vice Chair Joseph. And now on to Member Jansen.
Thanks. And yeah, I'm hitting the request to speak button with futility here, so thank you. I have a few questions actually to pick up on that. I'll do so in a moment. My questions were similarly to Chair Crutches here around the data and zeroing in, it caught my eye around the decreased deaths since 2021. It's something that I've heard about spoken in a few different circles before, and I'm wondering along the same lines whether there's been any sort of attributional analysis, any sort of causal analysis, at the very basic question, why are we seeing these reduced deaths? And I'll follow up that up with a comment, but maybe I'll pose that question to members of staff here.
Sure. So I can take that question. Thank you for the question. It's a very good one that a lot of researchers are working on as we speak. The answer I can give you right now is speculative, and it comes out of the Canadian Society of Addiction Medicine conference that passed in October in Montreal, where there was some speculation about this. The thought is that the opioid crisis was largely exacerbated by the COVID pandemic with the isolation, the loneliness, the abrupt stop in services, and then potentially exacerbated again by attempts to address those services. So people have mentioned concerns about different kinds of drug policies that may or may not be working. And so since 2021, people have had the chance to do more work for opioid use disorders and see what's been working, what isn't. In the most recent conference, there was some reconsideration of policies that were tried during the pandemic, what people think works, what people think didn't work. And so we're in an interesting time right now where these policies that were tried during the pandemic crisis that happened, that really left a lot of people vulnerable and increased our overdoses. So looking at both the pandemic response, and what we think is working now. So all of that to say, the pandemic, the response to the pandemic, and then now there's a lot of research trying to sparse out what works, what isn't working, and seeing where we go from here. I hope that answered the question a little bit.
Yeah, that's really helpful. Thank you. And I think it does speak to some of the complexities, and I appreciate that you're looking into this. I think I've heard it framed before as a justification for some of the policies that have been enacted over the past number of years and proof that they are working, again, in terms of the framing that I've heard around this. And I think, I guess I have one question. The first question for you, can we even know that, given the lag time in data collection, given the fact that many of the policies that were enacted, we still haven't actually seen on the ground yet. So, can we actually attribute this to any sort of a policy success? Framed conversely, I feel like it, morbidly, can we rule out that the decreased number of deaths is actually a sign of the failure of the system? That it's actually an indication that we have done things wrong, and now here we are that far past. Can we rule out either one of those two sides? I hope I'm articulating my question right.
I think what you've highlighted is how complex the issue is and how we have a lot of work to do, and people are actively working on trying to sparse out some of these things. So I can only speculate as I have, but I would say that work is ongoing and there's definitely progress being made. So for example, this year's conference compared to last year, there was some kinds of consensus forming. It's still really early to say though, so I'm hesitant to say more, but just to leave it at it's actively being looked at, and we're engaging partners, we're looking at the research, we're examining our own work and revising our strategies. So very much ongoing work. Thank you for the question.
Thanks. And I'm not seeing further questions for staff or any comments from members. So at this time, we have a mover and seconder already, I believe. Sorry. Oh, apologies. I didn't know you had more questions. Go ahead.
No, my mistake. Sorry. I have questions about a topic that Member Joseph brought up here. I didn't know if there was other speakers, though, who wanted to go forward.
Oh, that's not how it works. You keep talking until your time runs out.
Okay,
Go ahead.
you got it. On a different topic, again, following up from comments that Member Joseph made here, and that was brought up earlier with the delegate that we heard earlier this morning around the ability to know about some of the good work that is happening on the ground. I just quickly pulled up on the City of Hamilton's website about the drug strategy, and the last time that page was refreshed was September 2024. I wonder if there are ways that we can enhance or if the staff could speak to any of the ways that we are communicating to the public some of the active work that is ongoing, and perhaps that's a motion.
Through the chair to the member, again, thank you for the question. I think further to the point when Member Joseph had asked the question as well, I think that's work we can take back to the drug strategy and to staff and to the opioid working group around ongoing communication of the work that is happening from a public perspective. to continue to highlight these initiatives. So from public communications, we can take that back to staff on how we work forward from there.
Okay, now seeing that there are no other questions or comments, at this time, I'll need everyone to vote in favor of receiving this information report or opposed, up to you. Show of hands. Oh, I see Councillor Nan has her hand up. Okay, great. Everyone's in favor. Wonderful. Thank you. That carries. We're now on to update from members Danko and Jansen respecting their participation in the 2025 Association of Local Public Health Agencies 2025 Fall Symposium. And so I'll turn it over to the two of you if you'd like to speak to this item. I believe you provided some comments in writing, so you don't need to maybe go over them verbatim, because I think they're on the agenda if I recall, but happy to have your comments and summary and any questions people have. And I'll start with the person with the microphone on, Member Jansen.
Thanks, preemptive here. Yeah, so the conference was a good opportunity to hear about some of the ongoing work that's happening across the province. I will not repeat everything that I've written. It is in writing in the agenda, but 4 key topics in particular for this Board of Health. So first, the Indigenous Primary Healthcare Council spoke about the intersection between boards of health and legislation impacting Indigenous communities. And also in the main conference, PHO spoke about their Indigenous health and well-being strategy. And in this, there were conversations around the importance of local Indigenous knowledge, building relationships, self-determination, and respectful engagement, and the principle that I know has been discussed around the circle here of nothing about us without us. Several health units also spoke about their ongoing relationships with Ontario health teams across the province, highlighting partnerships that functioned as enablers while also having conversations around managing scope creep, and a very interesting conversation about ensuring that we are clear about the vernacular that we're using, especially with some overlapping terms around population health and population health management. There were some interesting conversations around here about the mutually reinforcing roles of public health in the upstream work that is played in terms of preventing people from requiring more intensive health services, and the role of Ontario health teams in terms of coordinating those health services in line with the quintuple aim. The Alpha Board spoke about their health human resources strategy, an interesting conversation about the role of artificial intelligence, which I wonder if Member Danko might speak to. Just a very interesting conversation, and the importance of the HPPA as the board's how-to manual for doing this work. And then finally, AMO closed with what I would say was an impassioned discussion, in line with some of our conversation here today, around the province's closure of CTS sites and the introduction of the heart hubs, noting that there is no clear evaluation model or framework for this new model of care, and a lot of questions around the province's decision to move in this direction, and that this fits in line with AMO's overall assessment that municipalities are playing an increasing role in meeting the obligations that are more typically traditionally provincial in scope. I'll pass it over to you, Member Danko, if you want to add anything there. Through the chair.
Thank you. Through the chair, such an excellent summary. And I think that a lot of the topics discussed in the conference really reflected conversations we've had at this table. I did want to highlight a couple of pieces I found particularly interesting around the potential use of AI in the public health system, as a number of public health units are already exploring how to use AI as a tool to improve our approaches to data management, particularly looking at our struggles around having one database for vaccination records, for example, in the province that we do not have. But there's a number of challenges that we face with respect to the use of AI, and really there's a major upfront cost associated with it, because all AI innovation will be ahead of legislation. So you have upfront legal costs to ensure that we're meeting regulatory compliance in the absence of clear guiding regulations. And so there was a suggestion that we could start to leverage the work of other organizations who are moving forward on both solutions and infrastructure testing perspectives that maybe don't have the private health information data that we're using and have access to. There's also the need to consider cybersecurity, but I don't think we need to talk about that in Hamilton. But there's a number of opportunities as well to consider what types of skills are needed in public health units, given AI is here and it's here to stay. And the speaker suggested we need to maybe reimagine what information technology and its design in public health looks like. They did note that the Wellington Dufferin Health public health unit now has data scientists as part of their staff complement, and they're taking an active role in looking at the uses of AI, again, in making public health more efficient and finding efficiencies in our current context of financial constraint, shall we say. They also mentioned, related to what we've talked about, how much misinformation, disinformation there is, how that can be magnified with AI, but also, how do we share the important work that we're doing and the value of public health work in our communities. And so they're also looking at other organizations that are leveraging AI to help, get that message out and to manage or interfere with mis and disinformation. So again, there's a lot of opportunities, but at the end of the day, it requires a lot of investment, front-loaded costs, and so public health really would need seed money to get the tools developed and tested and off the ground. And you need complex evaluations of the tools to show effectiveness and value, particularly in a space where we have to consider private personal information. So, the need for the province to understand this challenge and step up to help with some of that investment is important. And of course, the importance of working collaboratively across public health units is going to be critical so that the shared upfront costs could be mitigated. Thank you.
Thanks very much. And I see that Councillor Tatis had a question or comment to make.
Well, my question was going to be about the Canada's measles elimination status and how disinformation and misinformation and what strategies we were going to use to combat it. But I think Member Danko answered most of that with greater investment and better communication strategies. Thanks.
Okay, thank you very much, Councillor Tatis. I don't see any further speakers on the list at this time. And so at this time, can I have a mover and seconder to receive this item? I don't think I got a mover and seconder before. I think I just let people ramble on without doing that. Sorry, that was my fault. And that wasn't rambling. I'm just editorializing. Councillor Kassar, seconded by Councillor Huang. All those in favor of receiving the item? Thank you. We're now into items for consideration. 8.1 Board of Health 25027, the updated 2026 Public Health Services proposed user fees. Can I please have a mover and a seconder to put this report on the floor? Moved by Member Danko, seconded by Member Huang. Councillor Huang, is there any discussion about this? So I'm not seeing any immediately. I'm going to throw the chair over to Vice Chair Huang, who's acting. Thank you so much. So I'd asked about this at our last meeting, so I have a few things to say about it. I don't have questions, but I wanted to highlight what I consider to be what's in front of us and the choice that we have to make. So right now, the City of Hamilton uses a cost recovery model, and as the report outlines, that cost recovery model is not necessarily always full cost recovery. Sometimes it's less than that. By going ahead with the suggested updated proposed user fees, what we'll be doing is, if you look at the appendix number A, you'll see that there are some things like the first things there that are food handlers courses that we'd be increasing things for to get full cost recovery. And full cost recovery means that that's our staff's time that they're spending, right? And we're going to recover those costs from folks. And things like special event permits or special event late fees, those things as well. We're still not quite getting to full cost recovery on those. We're kind of only approaching half. Where it gets to be a little bit more difficult perhaps, or more costly, or you can see increases that are expensive, is when it comes to fees in the next section there on page 2. And so, for instance, if we look at a refreshment vehicle or food truck, for instance, we'll see that the costs for some folks are going to double in the next year with respect to food safety inspections. So let's just think of a restaurant or food truck or whatever it might be, food safety inspections. So some of the proposals are a little bit steep. Just so you know, those are annual costs. Those are not be happening multiple times, usually, is my understanding. And then we have some other fees increasing at reasonably moderate price increases here and there. So I'm just letting you know that for the certain classes of food trucks, for certain food safety fees with respect to restaurants that are at a high risk, those fees might seem expensive. When we look at the low risk, which would be your average situation at a restaurant, which does not have any inherently dangerous or inherently risky things going on that require additional inspections, the change in the fee there is 25%. So I just wanted to flag that for everybody because I think that this is a decision we're making. And the reason why we're making this decision, frankly, from my perspective, is because the mayor has chosen an arbitrary number and said, okay, everybody run to the number. And so this allows us to get closer to that number. We don't have to approve this. We could go with the original recommendation that was given to us by staff that they provided at our last meeting. And then this is an option if council wants to go down that road. And so that's kind of where I'm honestly headed with this, is to say that I really appreciate this work being done because it gives us a sense of, okay, what can we do to maybe offset our budget a bit? Where can we find a bit more savings by increasing user fees? But if we chose the recommendation that we already had, that seemed reasonable to me. This is an option that council can then exercise if they feel that's what they want to do. So for me, I'd rather go with the recommendation from our last meeting. Procedurally, that would be, I think, a little tricky, but that's not impossible to do because we have amazing procedural wizards with us today. But that's where I'm at. I'll let other people speak, and then I can come back on to move that motion when it seems right. So I'll take the chair back, and I will see if other folks want to speak. I see Councillor Chattison's on the list.
I just had a question for staff based on the Tobacco Control Act network funding. Said the reduction may have a minor impact on public health programming in Hamilton. If you did, I'm trying to understand, said if we did, I guess, do away with the $50,000, I guess it's kind of a contribution to that group. Would that actually bring it down below the 4.5%? And then what would be the impacts on public health programming at the street level?
Through the chair, can I just clarify, because that's in the subsequent report, it's not in this report?
Sorry.
Did you want us to go
That's in the
through that?
overall budget report, I believe.
Yeah, that's
so,
right.
So we'll just wait till the next one,
Okay,
and we'll
sorry
just
about that.
do the question at that time. Okay, other questions from other folks? Member Jansen, and I see Councillor Alex Wilson also. So Member Jansen, go ahead.
Thanks. Just a quick question, because I think some of those fee increases jumped out for me as well. And I know some of the conversation when we were here last as a Board of Health was around finding a balance between cost recovery and not putting undue barriers to folks who are doing community events, and ensuring that there is still that it's relatively easy for folks to be able to host events for their community and build community that way. I'm just wondering if staff could speak to that balance and how we would know if we are finding, or if that balance is off. Particularly, what mechanisms do the public or the community have to inform that balance specifically? Thank you.
Kevin McDonald, Director, Healthy Environments with Hamilton Public Health. Through the chair, thank you very much, Member Jansen, for the question. So subsequent to the direction of this past October to assess and provide alternatives, this is exactly what staff went away and did in concert with our financial services team. User fees are annually reviewed and assessed, and we have a boots on the ground real-time sense of affordability in terms of direct feedback mechanisms from the various user groups, the various individuals or groups in the community who pay these fees. There is a historical aspect to this in terms of, for a number of years, we've applied the corporate guideline of inflation. We haven't seen significant increases in these areas in a number of years. And the recommendation that was put forward in this report to strike a balance of mixed fees between 100% cost recovery, for example, for vape retailers, as Councillor Tadson referenced in October, versus special events and festivals, for example, where we're providing a more graduated stepped approach. This board could ultimately decide that stepped approach is enough. We're going to take a moratorium on that in subsequent years, or they could, you could, as a board, direct us to, over a sequence of years, pursue full cost recovery more incrementally, so it's not providing as much burden on the individual user that's paying that fee. And so historically, the direct dose response is what we hear. When this information becomes public, as it is now, often users will contact their representative and say, this is too high for these reasons. We get direct feedback. Generally, what we're hearing over the past couple of years is not that much pushback in the sense that we've applied the inflationary guidelines solely.
Okay, thank you. Councillor Alex Wilson.
Thank you. I appreciate this is a bit of a difficult question, so I'm comfortable with a rough or a broad answer, but I'm just trying to get a sense of the frequency of some of these activities. So for example, within the subset of food trucks, are there maybe dozens of high-risk inspections going on a year? Would it be possible to just give some flavor to the relative breakdown within the classes, as well as just, we're only doing 1,000 of these for food trucks a year total, or just getting a sense of, again, the scale, the number of times staff are doing this. I'm just trying to wrap my head around some of the sizes here.
So through the chair once again, anticipating your question, Councillor Wilson, I invited Richard McDonald, who's the manager of food and water safety, to join us today. Richard's group is responsible for carrying out these inspections on an annual basis, and so I'll turn it over to Richard.
Good morning, Richard McDonald, Food and Water Safety Manager. Through the chair, to broadly answer your question, is that so refreshment vehicle class A, B, and C would be considered a high risk, a moderate, and a low risk. In the city of Hamilton, we have approximately 200 vehicles or food trucks, mobile vehicle, refreshment vehicles. So from those high risks, there are maybe 9 to 10. For the moderate risk or class B type vehicle, we have about 80 or so, and the low risk ones are about 90, as far as numbers go, of actual vehicles.
Thank you so much. And then apologies for just not having another class ready to go, but I think my question is just in general, is there another area of these fees where there's maybe a substantive change being put out that there's a high number of inspections? I'm just trying to get a sense of, is food trucks representative of the largest kind of number of inspections? I'm imagining restaurants or other food services generally is the largest, so not food trucks specifically. Could you help me understand what a high risk versus a medium risk versus a low risk at a very high level is?
Certainly.
As a tangible example, I understand they have different levels of risk, but what does that look like?
Certainly, through the chair. So if you look at how we risk assess each of these types of vehicles or restaurants in general, they are assessed as high, moderate, and low. A high risk food safety inspection would occur approximately 3 times in a year. A moderate risk would be 2 times a year, and a low risk would be annually. So it gives you a sense of, out of those 210, if it was, for example, there are 10 high risk refreshment vehicles in the city, they would receive 3 inspections in a year. A moderate would receive 2 times inspections a year, and then the low risk would be once. And that would be the same for bricks and mortar restaurants and things of that sort.
So is a cafe, for example, a low risk and a butcher a high risk? Just could you pick a business that goes in maybe each category just so I have an understanding?
Certainly, through the chair. So a high risk, you would have multiple food preparation steps with very high risk foods. So for instance, if you were making ground beef burgers from scratch, okay, to give you a sense. A moderate risk would be things like frozen foods, some prepackaged foods that still require some food handling and assembly, but may need a heating process as well. So that would be sort of your moderate risk. And then your low risk would be strictly prepackaged, ready to eat foods, your convenience stores of the world, or that would have, chips, pop, things that a customer could simply just take off the shelf, pay for, and leave.
I'm not seeing further questions or comments at this time. So if I could pass the chair back to Councillor Huang. I know there's some alternatives here in the report, alternative 1, 2, and 3. Could you let me know which one of them was exactly the same recommendation that you made at the previous iteration, or if it wasn't any of these? That was my only confusion there, was whether or not one of the alternatives already captured that. Might have been alternative 1.
Dr. Richardson, please.
Yes, sorry, I'm just navigating back. I was looking for some of the answers to the other questions that I knew were coming. Let me just find the right tab. This one. No, not that one. Have you guys got it open? I'm having problems with my thing. Let's see this one. These are finished. So it would be scenario 1, which is the inflationary increases that we had proposed the first time around. And then this is scenario 4, which is the mixed cost recovery. Yeah,
Right.
sorry about that.
And so I guess what I would probably be asking through the chair is for whoever moved and seconded putting the report on the floor just to withdraw that motion, and then I could put forward my motion to just go to alternative scenario 1.
So through the chair, we could also just amend the appendix with the numbers to the original as well as another option.
Sorry, help me understand that a little more.
So we have the list of proposed fees, so
Yep.
we could propose an amendment to the proposed fees to be what it was at our last meeting.
Oh, so then you're just moving
An amendment.
an amendment, okay.
It's fine with me.
All right, does everyone understand what the activity here is?
I could also show the proposed
Yes, if you
from
can
the
put
last
that,
meeting as
if you
well.
can put that up on the screen, please. Can you increase it just a little bit? Thank you. So that was from the first time around. And Councillor Crutch is moving an amendment to revert back to the inflationary budget, which would have been in alternative scenario 1. Is that correct? Is there a seconder for this? I do not see a seconder. Oh, Member Jansen. Oh, I also see Dr. Joseph as well. So there is a mover and a seconder, and would you like to speak to your amendment, please?
Yeah, could I ask the clerk to go down a little bit? Okay, the reason I asked that is because I know that some members here had asked one slight adjustment. If I recall, Councillor Taddison had said that, and you'll have to help me, Councillor Taddison, to remember, but I believed it was items 8 and item 9 that you said you wanted to have them be fully cost recovered. Item 8 already is, but item 9 isn't. Is that right?
Yeah, I think I just asked why we weren't seeking full cost recovery, but especially I guess it would be for 9, because 8 is already fully cost recovered.
So I'm totally happy to have that as a friendly amendment to here, just that we, on item 9 there on the second page, I believe it is, for it to just be fully cost recovered.
So I believe it's the electronic cigarettes.
Yeah.
What we're referring to, so it would be 8952.
Right. So that was the only other change I was thinking to make. And I'll just speak to it briefly and explain why I'm suggesting this. We do this because, and I really appreciate the staff did this work, right? But I think it's council's job. If the mayor is going to put forward a motion saying we want to have this arbitrary number be met, and if council in its infinite wisdom decides that that's the way to go, then council can make that decision, and we now have the actual information to be able to make that decision effectively. I still don't think it's our job to be doing that. I think that what you've been doing makes sense. I do think, though, in the future, we should think about full cost recovery. I will also say, with caution, I'll say this, that we're a municipality that's doing this. Not every municipality is doing this, right? So the cost recovery model we're using is not what every municipality around us does. So as you can imagine, some individuals who are getting public health services from across the general area see, some dissonance there, right? We're doing one thing, these people are doing other things. So it's important for us, I think, to review this and have that conversation in full to understand why. Every municipality is different. We have different needs here, so there's reasons why we're doing certain things, but I think we should go with the previous recommendation with that slight amendment and then let council make the decision of what they think is best.
Okay. Any other speakers on this? Oh, Dr. Richardson, please.
So just wanted to clarify sort of two things. Just one is for the clerk with Matt in terms of the numbers that we're reverting to. So the 3.6% inflationary increases, which would have a slight increase in revenue, plus if we used 100% on the vape, it's another $18,000 worth of revenue. Just for Matt, we just have to be careful in the numbers that we use as we go forward because the budget has changed since that report as well. So that would bring it down, that would not go back to 5.7%, it would go back to 5.8% plus that bit for tobacco. So just wanted to be clear on that as we compose any motion. The second thing is just from a process perspective in terms of who approves these user fees, just want to be clear that what would have to happen is that this would be sent as the board approved, part of the board approved budget. So these user fees per se don't go to council for approval. They're approved by this board. And then if council wanted to change, they would refer it back to board for consideration. So I just wanted to make sure that people understood the process as being our first year.
Okay. Thank you very much, Dr. Richardson. Any other speakers? Councillor Taddison, please.
I'm going to be supporting, I guess, the recommended scenario 4, so that would probably mean that I vote against the amendment. Okay, thank you, even though it supports my one piece there with the electronic cigarettes. Thank you.
Thank you, Councillor Taddison. Any other speakers on this particular topic? Councillor Alex Wilson, please.
Thank you. I just want to make sure that I understand this with the respect to the clarification that the CMOH just made with respect to the budget reference. The point that you were making to the clerk about it changing the overall 5.7, 5.8 percentage, we're still just end of the day, like the projected revenue is for all of these programs, the difference is roughly $240,000 total, and then the 20-ish thousand dollars from the nicotine doesn't count. So I just want to make sure that that's still the total with respect to any global changes.
Chief Medical Officer, please.
Sorry, could Member Wilson
I'm just making sure that I maybe got a little confused when you were clarifying with the clerk earlier when you were talking about the budget shifting across meetings. The total amount for these fees is still roughly $240K, the difference that we're talking about here. I'm seeing some nods from other committee members just seeking confirmation that that's not up in flux with other budget changes.
Through the acting chair. So no, that's correct. The amount, the quantum we're talking about is $240,000 with the amendment. But I just wanted to say if we're composing about the overall budget, that number has changed.
Thank you. Okay, yes, thank you.
Okay, thank you. Okay. Seeing as there are no other speakers, we'll call to vote. At this time, again, just a reminder that this is an amendment that goes back to reverting to the original budget number plus the friendly amendment of item 10. So that one is up for a vote currently.
Member Safi, I just need whether you're in favor or opposed. In favor?
Are you in favor? Is that,
in favor,
okay?
yeah. Thank you.
Member Joseph, is that a thumbs up? Thumbs up, please. Okay. Sarah, is that also a thumbs up? Yes, thank you. That vote carries 9-3. Chair is back to you, please.
Thanks very much. And now we're on to the budget itself. Board of Health 2502.
Sorry, through the chair, it would just be as amended.
Oh, pardon me. As amended, we have to have another vote. So that's not me. Is it you, Councillor Quine? It could be me, apparently. That's fine. As amended, apparently, because we're back to the main,
Okay.
the main report.
No, but didn't I move this? All right. Vote is up. We have a mover and a seconder. Vote is up, please. User fees as amended.
Member Safi, are you in favor?
Just thumbs up. Thank you.
Thank you. Thank you, Member Joseph.
Thank you. Vote carries 10-2. Thank you.
Okay, and we're on to 8.2, which is Board of Health 25028, which is the Public Health Services 2026 proposed budget. Can I please have a mover and seconder to put this report on the floor?
Sorry, Chair, apologies, I should have done it before the vote total. If I could just ask one final question about the last report, not about the vote, but just about a follow-up report that's coming.
Sure.
The report mentioned in the next user fees report an exemption, a consideration of exemption for nonprofits. Just wondering with staff what the intent is to have conversations with the seat team, or what are like options being pursued. So would it be only looking at, say, an exemption for a nonprofit hosting an event? We just wouldn't charge them the health inspection fee, or would a potential program that says the city has a pot of money, up to this much money to incentivize these things? I'm just trying to wonder the types of responses back. Are you only looking narrowly at a exemption, or is there more types of solutions being looked at in that process?
Thanks, and we're just rewinding the clock back to the previous report briefly to get an answer to this question.
Through the chair, thank you once again, Councillor Wilson. Kev McDonald, Director, Healthy Environments Division. Our initial plan was to look strictly at the language that was used in the motion around an exemption for not-for-profit organizations. Certainly, we're open to direction if you want a broader assessment done.
No, thank you. I just appreciated understanding what the goal was, so we all understand the direction when it comes back and what was looked at. Thank you.
I'm going to take a real long pause here just to ensure that I haven't made any omissions, to see if anybody else wanted to speak to anything before I move to 8.2. Okay, on to 8.2, I need a mover and seconder to put the report and correspondence on the floor. Moved by Councillor Taddison, seconded by Member Danko. Is there any discussion on the proposed budget? Councillor Taddison, and then Vice Chair Joseph.
Just going back to that original question that I asked at the inappropriate time. The reduction may have a minor impact on public health programming in Hamilton, and that's if we shift the 50,000 K away from supporting, I guess, a more broader regionally focused tobacco and vape control activity. Can you just, what's that going to look like on the ground?
Through the chair, thank you very much, Councillor Taddison, for your question. So just to reiterate what's contained in the report regarding that funding stream, it's a historical funding stream from the province of Ontario dating back to 2008-2009 when they renewed their Ontario tobacco strategy. Many health units across the province in recent years have already drawn down their regional dispersion of funding for tobacco prevention protection. It's largely around communications initiatives or initiatives in kind with other health units. Dr. Richardson has been in communication with her counterparts across the region to let them know that this is a budgetary consideration for the City of Hamilton. What I would say is this puts us in more lockstep with our counterparts across the province who served as these regional hubs and does provide an option for reduction. This was provided in the context of the earlier user fee reduction as well to highlight additional savings should the board wish to pursue it.
Okay, thanks for that. I did see somewhere where it said it takes it down from 4.5 to 4.2. Is that $50,000 represent that 0.3?
Through the chair, that's correct.
I just say I'm astonished by that. Thank you.
Thank you for noting your astonishment, Councillor Taddison. We're now on to Vice Chair Joseph.
Hi, just a few comments. I appreciate the proposed budget and all the ways that it has been careful, that folks that put it together have been careful to think about, what's possible given current financial context. And also, in addition to this, the correspondence from the mayor that sets a somewhat arbitrary limit to budget increases. I think, as the Board of Health, drawing on what is known in terms of what services needed to be provided and costing that effectively and thinking about that carefully, I think it's the kind of thing that should happen to meet the needs, to provide the services that are required. And that will have a budget. It will have a cost, and it does. What happens politically with the decision I think should not really impact what's brought forward as a budget to meet the needs of the community through the services provided through Hamilton Public Health. So I say that to say, I understand the mayor's proclamation, and I don't think that should impact what is brought forward in terms of what the budget actually empirically is to maintain services at an adequate level for the Board of Health. So I approve. I would vote in favor of keeping the budget to where it needs to be, as recommended by Hamilton Public Health, without really finagling to meet some arbitrary point raised for another kind of reason. If it was, said to be decreed that all that could be approved is this amount, and then a budget would be to have to be revised to share the impacts of what that reduction would do in terms of what services would be impacted. I feel like that's another piece of work. But before us, I believe we're meaning to approve the budget created for us to meet the needs, the service needs for Hamilton Public Health, and that other political consideration from the mayor is a different set of considerations.
Thanks very much. And now, Councillor Huang.
Thank you, Chair. Just a quick, maybe not quick, I just need some clarity. In the report recommendations, it says that this is a budget of 4.5%, but I think in the appendix, it actually allocated the 4% from the proposed budget, proposed user fees, which we changed just now. So what is our current budget now?
Through the chair. So this is what Miriam, who is our business analyst who works with us in public health, and David Trevisani, who's our finance manager, have been working furiously on as you've been debating. Is going back and forth amongst the numbers and what they would be. And so Miriam's just calculated that the overall budget would remain the same at 65.5 million, which would, it's 64, yeah, no, it's 65.5 million and at 2.1%. But the levy portion would be with the user fee small change would be 18.7 million for an overall impact of 5.7 million, 5.7%.
5.7%. So do we need to change the recommendation to reflect that? So that way in recommendation 1, it says the net levy portion of 18.7 million or 5.7% over 2025 public health services budget be approved. Is that the way that we have to do that?
That's correct.
So Chair, I don't know if that needs to, how that, because all of these numbers have changed, so is that something that I can just move to make sure that that's reflected correctly in the recommendation?
I just assume that it will be. Like, I think everyone's got it here. Do we have to have a special motion to do that, or just the impacts from the previous changes will be reflected? We have a motion to make sure they're reflected?
Yeah, we can do a motion.
Okay, so I'll just move that just to put in the clarity there.
Sure. Somebody want to second that? I see many hands. We'll go with Councillor Kazar for fun. Everyone understands what's happening here and what we're doing? Okay, we'll probably need an electronic vote for this. So I'm just going to give that over to the clerks to let us know when they can get that up. And that vote is now up. If you don't have access to the eScribe system and you're in favor, you can just give a thumbs up. And if you're not in favor, you can give a thumbs down, and we'll record your vote in that manner.
Member Safi, I just need your thumbs up or down. Thank you.
Up, okay, and same
Thank you.
with Member Joseph. Thank you. And that carries 11 to 1. Okay, I don't see further folks on my speakers list with respect to this item. So we'll go to the electronic vote. And the vote is up.
Thank you, Member Joseph.
Leave the vote open for a couple more seconds there if you don't mind.
Sorry, Member Safi, is your thumbs up? Thank you.
Okay. And that carries 10 to 2. Thank you very much. We're now on to motions, and I'm saying that because although the motion I put forward was withdrawn, there's another motion that's come forward in its place about a previous report on the agenda, and if you haven't seen that in your emails yet, it's been circulated. I could ask whenever the legislative coordinator is available to put that on the screen. That would be wonderful, so we can have a look at it. It's with respect to the discussion we were having about report. I'm just going to try and get the number of it. 7.2. Okay, it'll be up on the screen shortly, and then I'll make sure everybody knows what it says. And normally I wouldn't have someone ask someone to read something into the record, but since no one's seen this, Vice Chair Joseph, if you wouldn't mind reading into the record, and if you could make this a little bit bigger for everybody, that'd be wonderfully helpful. Legislative Coordinator. This is not a notice of motion. Someone has asked that this is a notice. No, because it's related to a report on the agenda. So it can come forward today. If there's a general consensus, people really want this to wait to the next meeting, we can have that conversation. But I think it follows pretty closely the conversation we were having. I think it's just been written quickly. I think the seconder here is Member Jacob, who suggested some revisions by email, if that's okay with you, Member Jacob. Otherwise, Vice Chair Joseph,
that's fine.
if you could read your motion into the, thank you, if you could read the motion into the agenda just so people can hear it.
Sure. It's directly related to what I raised earlier about reporting. So begins, whereas Hamilton continues to experience significant public health harms associated with the toxic and unpredictable unregulated drug supply with ongoing impacts reflected in paramedic responses, emergency department visits, hospitalizations, and deaths, and whereas opioid-related harms disproportionately affect equity-deserving populations in Hamilton, including individuals who are unhoused, Indigenous, racialized, whose experiences are shaped by systemic factors such as poverty, housing instability, stigma, racism, and barriers to care, and whereas data demonstrate that the largest concentration of opioid-related paramedic responses and Van Needle syringe program service stops occur in wards 2, 3, and 4, indicating a geographic concentration of risk and the need for targeted, equitable, and community-specific interventions. And whereas toxicology information shows that most accidental opioid-related deaths involved multiple substances, including fentanyl, stimulants, cocaine and methamphetamines, unregulated benzodiazepines, and veterinary tranquilizers, reflecting a highly toxic and evolving drug supply that increases the complexity of emergency response and overdose prevention. And whereas Public Health Services, in collaboration with the Hamilton Drug Strategies Opioid Working Group and the Greater Hamilton Health Networks Harm Reduction and Treatment Working Group, continues to undertake harm reduction, monitoring, and treatment initiatives aimed at addressing the risks associated with the unregulated drug supply. And whereas the current semi-annual Hamilton Opioid Information System reports provide important data on harms but do not consistently include a summary of public health's ongoing initiatives, actions, interventions, or programmatic responses aligned with the issues identified in each reporting period. Therefore, be it resolved that Hamilton Public Health Services include in all future semi-annual Hamilton Opioid Information System reports a dedicated section that, one, outlines all current initiatives and interventions, harm reduction actions, community partnerships, and program responses undertaken by public health that directly respond to the issues, trends, and inequities identified in the report. Two, provides progress updates on ongoing strategies and actions addressing harms related to the toxic unregulated drug supply, including updated data about drug toxicity to contextualize the potency of substances in circulation. Three, identifies any new or emerging public health actions implemented between reporting periods. And four, describes how these actions align with and respond to the documented inequities, including impacts on unhoused residents, Indigenous communities, racialized populations, and neighborhoods disproportionately affected by opioid-related harms, as well as opioid-related health and social impacts beyond death.
Thanks very much. I'll pause here to see if any folks have comments or questions. I think.
Oh, sorry, I didn't read 5.
Oh, pardon me. And I didn't catch that you didn't read 5. So go ahead and read 5, please.
So 5 is to describe the impacts of policy changes. For example, the Restricting Public Consumption of Illegal Substances Act, including the current status of supervised consumption sites, including closures, relocations, and the number of people served.
Okay, there's a couple of steps we have to go through here. Step number 1 is we have to make sure that staff understand what the direction is to them, what's achievable, and the timeline. But we also have to give a chance for people to comment, and then we have to vote. So first thing I'll do is I'll just turn over to staff whenever they're ready, just to see if they have any questions or concerns about this.
How about I start off with an overview, Chair, and then I'll turn it over to Dr. Shakori.
Sure, I think we're just looking to find out if you think there's any roadblocks here, or go ahead. Yep.
So there's sort of 2 pieces to it. One is, or I guess 3. One is the toxicity data that we have. Just wanted to be clear, we're giving you what we've got, and we'll continue to do that. So just wanted to be clear, there's not additional information that we have. The one piece talked about public health actions related to this. It uses a small p, small h, as opposed to a public health services actions related to this. So I'm assuming that the board wants broader actions across the health and social service system that are being taken about this.
So I'll pause here. And so the board hasn't really written the motion. The mover and seconder have. So I'm going to turn to the mover, if you don't mind, to answer those 2 points. So number 1 is recognizing that there's not more toxicity data that we're not providing. I think you understand that. And then number 2 is just asking what the intention behind the 2 words public health was. If you could elaborate a little bit.
Sure. Which item? So they're numbered.
I don't have them in front of me now.
Through the chair, I believe it's 3, identifies any new or emerging public health actions.
Yeah, so the question to you, Vice Chair Joseph, is just whether or not you meant public health services actions with respect to our public health
Yes,
staff,
sorry.
or you meant broadly?
No, not broadly. Specific to Hamilton Public Health Services. Excuse my lack of capitalization there.
Fine, we're writing these things on the fly to a certain extent, so capitalizations can be excused. Dr. Richardson, does that answer your question?
Yes, that's helpful. Thank you. And I want to clarify that the Hamilton Drug Strategy is not a public health services table. It is public health service that provides the Secretariat, but it's a community table. So we wouldn't include that there. That would come forward in separate reports that come from the drug strategy itself.
Okay.
And then the last piece is just number 5, in terms of a policy analysis to look at those impacts. As Dr. Shakori had mentioned earlier, that is and she can go on and expand on that piece, that's a much bigger piece of work that we wouldn't have much to update whatsoever in those. That's going to take some time. And Dr. Shakori, do you want to go ahead and address that one?
Sure, yeah. I would just add through the chair that I really appreciate this motion as responding to an opportunity for improvement that we all identified earlier to ensure that the public and the board is kept up to date on our activities and our services. The main concern that I had, echoing Dr. Richardson, was that piece on describing the impacts of policy changes. That work, as I mentioned, is ongoing by researchers across the country and is not something feasible for Hamilton Public Health Services to be doing, but we can definitely stay on top of it. I just wouldn't put that specific clause in this motion.
Okay, so a couple things are happening at the same time here, so I'm just going to pause briefly and ask an important, I think, clarifying question. When is the next report due to come back on this issue? Because it all relates to trying to come back with some information in time for the next report, so I'm trying to make sure I know when that is.
Through the chair, the next semi-annual update would be June 2026.
Okay, so a question to you folks is, if there was some time offline to do some wordsmithing to get this in a place where I think it might be a little more clear, and we brought it back to the January meeting, would that still give you plenty of time to do the work regardless in time for June?
Yes, through the chair, yes.
I would say to the mover and seconder, if it's okay with you and you don't mind just clarifying this language and working with public health staff to make sure it's completely accurate, so they're bringing back exactly what you're asking for and exactly what they can, and bring it back in January, that would be helpful. We can spend some time here today if you want, going back and forth and wordsmithing until it gets to the right place. I think that's going to be challenging. So I'm just asking if maybe you wouldn't mind bringing it back in January, but it's really up to you.
Sure. I also, I think, working with board members to draft the motion and bringing it forward is one process. What staff can currently do and what we ask them to do in the future, will change by virtue of what we decide through the motion of the board. So there's some finagling pieces that I think can be difficult. And what I mean by that is it's not to not appreciate what's currently being done. It is to ask for more, and that ask is going to happen. And if it's not currently possible, the idea of the motion is to make new things possible.
Yeah, I don't think anyone's saying that they can't do new things. I think what I'm hearing are 3 things. I'm hearing a request for making sure that the language completely reflects exactly what we're able to do, asking the right people to do the work, right? So if it's, for instance, a group of individuals who aren't accountable to public health, how do we ask them to do that? That might require us, me as a chair, writing a letter, for instance, to those folks, asking them to do something or making a request to them. I think this is just about making sure that it's all straightforward so that we actually enact the motion. There's not some unintended consequence where we say X and then we ended up hoping for Y and we end up getting G. And then we're all like, but we didn't ask for that. I think that's what I'm hearing from staff to a certain extent. They're all shaking their heads. You can't see them in the room. I think it's just about just making sure it's quite accurate. And then again, if ultimately there's something that there's a disagreement about, for instance, like staff say, well, we don't do this or we can't do this or can't offer this, and the board says, well, we want you to, that is our legislative job, right? So we can bring that forward. No one is suggesting otherwise. So I think it's just a matter of trying to make sure that the right wording is there, and that we do it in a way that is technically correct. Member Jacob, I see you there.
Yeah, so I appreciate what's being said, and I also don't want to delay this motion unnecessarily if it's possible to have it go through at today's meeting. So I recognize there's maybe a number of things that would need to be revised. I'm proposing perhaps then the striking of the 5th, the one that specifically talks about the policy piece, and acknowledging that perhaps some of the data that is already being collected reflects timelines that coincide with some of these policy changes and could perhaps be looked at retroactively for comparison. So I'm just saying that I'd made that amendment to add that to the motion that was being presented, and I'm okay with that being removed, if that might hasten today's discussion. But if there's other issues, I'm also okay with us delaying until January.
Yeah, I'll pause and look to the bench. If this discussion goes on for even 5 more minutes, we're just going to take a recess so people can sort it out. So that's where I'll be at with this. I'll ask Dr. Richardson. I don't think that's the only thing that you were suggesting needed to be changed in terms of clarity, but I'll let you speak to that.
Right. I think the toxicology piece, I think we're clear on, that I had raised. I think the second item that I had raised was about, was it small p, small h, meaning health and social service system really more than public health, or was it specific to public health services? So what I heard in relation to that was now capitalize it, public health services. So if that's an amendment that was okay. And then the last one I heard was being struck to just ask for data that coincided with those policy changes, which is, I don't see that as a change to the report that we have right now, except to flag when the policy changes happened relative to the line graphs that you're seeing. And so that's completely doable as well.
Okay, so number 5 seems like it's doable and fine. So I'm just going to pause briefly, look to staff and say, based on the discussion we've had thus far, are you fine if this goes forward today, understanding we've made some small amendments? They seem fine. Okay. I'm just going to take a breath and a pause. Seems like we can move ahead with this. Some amendments were made that seem to be fine. I think they were looking for us to acknowledge those amendments. Are those amendments fine with you as the mover and seconder? And we're going to leave 5 in, it looks like. Matt. Okay, while we're looking at those,
So,
Jansen,
sorry.
go ahead. Vice Chair Joseph, go ahead, yeah.
I think item II, Dr. Richardson indicated, the part that starts including updated data about drug toxicity, that is already being reported on. Is that correct, Dr. Richardson?
Through the chair, that's correct.
Okay, so we can remove that part.
Okay, any further comments on this before we go to the vote?
No, removing that part. Yeah. Okay, there we go. Cool.
It's been removed, yeah.
Excellent.
Okay, Member Jansen?
Thanks. And I think at a general level, I would agree with some of the conversation that says that there is a lot of ongoing work and making sure, like, I think that everything in this motion is important and useful, and also I don't know, in terms of the ongoing work that's been happening across the community, across Hamilton, I think that it would be good for there to be more discussion and make sure that this motion gets at some of that at a general level. At a more specific level, I just have a question of clarification to the CMOH here about the conversation about capitalizing point 3, and I believe point 1 as well, and whether that will exclude the work that's happening through the Hamilton drug strategy. Can you clarify? I think you mentioned that that is a community table, and so capitalizing public health service would not then speak to any of the work happening at that table.
Through the chair. So it is complicated around the drug strategy, and understood. And so often we'll reference it in terms of what is going on, but in terms of formal reporting, we do think it's best if there's a desire for formal reporting from the drug strategy for example, on a regular basis to report back on its actions, that go to the drug strategy and ask, it's an ask to them. It can't be directed to them to do that, and they have to be in agreement with what they want to report back. And so we do provide updates in terms of the opioid table, for example, and whatnot, but if it's a more broad sort of piece, I would say that it should actually be a request for reports.
And that would be a totally separate motion that you could bring forward at a future meeting. So you know sure exactly
that speaks to
what
another
we're
point
asking.
that I have here,
Right.
yes.
Yeah, so it seems like we're trying to do that separately, and so this is an ask of public health services, and then if we want to ask some specific things of the drug strategy with respect to reporting, happy for you to bring forward a motion and work on it behind the scenes, whatever you want to do for the next meeting. And again, that shouldn't delay things, and neither will this motion delay anything either. We're at 11:22, so I want to really wrap this up or take a break and have a recess to discuss it further. Yeah.
Sorry, absolutely, yes. And totally recognize that could be a separate motion, and I think should be a separate motion. Again, now going to point 5 on here, if we're keeping this in, I mentioned this at the last Board of Health, that Guelph is doing, to my knowledge, and I wonder if there's been any further digging into this, that the Guelph Board of Health has been doing some digging into the impact of the closure of their CTS site. I saw about a week ago that Toronto Board of Health is doing some investigation into, again, the impact of the closure of the CTS sites on their community. And I do think that any 2.5, which my screen has now closed down, the impact of policy changes, I think, ought to be done with, in particular around the closure of the CTS sites, ought to be done with those health units who saw the closure of their CTS sites. I believe we saw 8 closures across the province. I think liaising with those 8 health units to make sure that we have consistent data and so that we're able to see consistently across the board when you close CTS sites and remove a service within the community, here's the impact that this has on the community, not just in Hamilton, but also more broadly across the province. So I don't know if that's a friendly amendment to 0.5 there around consultation with those health units that specifically saw the closure of a CTS site, or whether that's a separate motion.
I don't know. I'm looking to staff to see if that's something in scope that they can do.
Through the chair, so that would be a usual sort of reporting back around something as we would look at what others were doing and make comparisons, especially to peers. Sometimes it's to Toronto because Toronto is large and does a lot of work, and that other health units aren't able to do, I should say. And then sometimes it's because it's others that are leading in that particular area. So it would be in scope for us to do that. Yeah.
Okay, so if that's okay with the mover and the seconder to add that item, I see first Vice Chair Joseph and then Member Jacob. And these are the last comments I'm taking before I actually literally do take a recess so you can all talk to each other and figure out what you want to do, because we can't go back and forth on editing a motion for extended periods of time in public. It's not what we do here at the Board of Health or anywhere. Member Joseph, go ahead.
I was just going to say the motion and the kinds of things that asks for, we in the back and forth, we're also going to add a specific note that said that relevant websites would be updated accordingly to share the information of kind of what's happening and what people are doing with the public. If that's not an automatic thing, then that could be something that we add to the as a
I need
6.
to get back to Member Jansen's point, though, but whether or not that's a friendly amendment, that's the most important thing on the table right now. So
Yes, I'm good with that. Yeah.
Okay. In terms of adding something else to this motion, before we could entertain that, Member Jacob, did you have any comment to make about this? Because you had your hand up as well.
I did, yeah. And actually, Emil has made the exact same point that I was going to make, so I don't have anything to add at this point.
So if there are relevant websites that the City of Hamilton already maintains that have information related to this, that we update those websites with any relevant information, is that what you're suggesting? I see a thumbs up. I'm looking to you folks over here to see if you have a response to that before I call the question.
Yes, absolutely, Chair. So just again, want to be clear, our websites, yes, as we go forward, you know that there's a communication strategy. We're going to come back and talk about that in January overall. You remember that the board had asked for that, and that does include updating these kinds of websites and those sorts of means. So, absolutely that's doable. Again, just want to be clear, that'll be public health's information. If there's anything that any other group wants to update on, if the GHHN wants to provide updates on things, if the drug strategy does it, that's up to them. And we're happy to make links to those as to the extent that they would want to do that.
Okay, so yes is the answer. That's going to happen automatically, and there's going to be a report back on how we're doing that in the new year. And then if the motion wants to come forward with respect to something else around the drug strategy, to ask them to do something, we can make a request separately through a different motion. Otherwise, I think we all understand where we're at here. In terms of this motion, we've made a couple of friendly amendments. It's on the floor. We'll go to the vote. Member Safi and Joseph are both in favor. We're just waiting for the vote to come up on an electronic system, and it's of no deficiency of ours. We're just making sure it gets copied and pasted in there properly. Okay, it's up now. Okay, that carries 12-0. And looking just to make sure, we need to confirm the bylaw for today's meeting. So can somebody move that we approve the bylaw? Member Councillor Huang and Member Danko. Any discussion on the bylaw, which would be a first, but hey, not seeing any. All those in favor, we'll do this electronically as well. And Member Joseph is in favor, as is Member Safi. That carries 12-0. And being that there's no further business at today's meeting, the Board of Health is adjourned at 11:28 a.m. Have a great day, everybody. Thank you.